So lastly, we discussed left ventricular hypertrophy, and in this video, we're gonna discuss the right ventricular hypertrophy. Before we move on to the RVH, let's just understand few core basics about RVH. There are three types of RVH, and that's mostly based on the etiology and how the RV gets affected. First is the pressure overload. In this, we have examples. For example, there's pulmonary stenosis, patients with TOF or primary pulmonary hypertension, which is also called as pulmonary arterial hypertension. So these are the patients who will have a lot of pressure on RV, and RV might just grow as big as LV or even overgrow LV. And this is going to have different presentation on ECG. Next, we have volume overload patients. For example, ASD, and there are few subset of mitral stenosis with mild to moderate pulmonary hypertension. They also have some volume overload because of pulmonary venous hypertension. And these are the patients which will have different presentation on ECG. Now we move on to the pulmonary causes, for which is called as pulmonal, and also your acute PT sometimes can have this ECG. So these are the types of RVH based on the etiology and how it anatomically changes the heart, which is pressure overload, which is type A, volume overload type B, and all the pulmonary causes are included in type C. So the ECG presentation of all three is going to be slightly different, and let's just discuss the same. So now we move on to the what happens in the QRS wave when there is RVH. So first and the foremost is right axis deviation, which is almost must if you have to describe the RVH. In type C of RVH, that could only be the finding and nothing else might be visible. So right axis deviation is must. Now let's understand these 3 points which are respect to lead V1. So QR in V1, this is capital R in V1. So the R wave in the V1 lead is going to be tall. This is your R wave. That is why, because the V1 is always placed on the right side of the heart, and it is corresponding to the right ventricle, which is right ventricle is also placed anteriorly, and this is the closest lead to the right ventricle. So R is going to be present in lead V1. The R in V1 is going to be more than equal to 7. So this is going to be more than or equal to 7. Again, this is the same point emphasizing that this R to this S ratio, R by S, is going to be or more than equal to 1. In the LVH video, we talked about delayed onset of intrinsic or deflection, which is nothing but when the ventricles are depolarizing. This is from the Q wave. This is called ventricular activation time. So when the RV is depolarizing, let's say in the lead V1, and it reaches the peak. So from the peak, whenever there's first deflection, this is called as intrinsicoid deflection, and this time for ventricular activation time in LVH, it was more than equal to 0.05, but the RV is relatively small, so it's going to take less time. And here they say more than or equal to 0.04, or you can just say more than or equal to 0.03, which is same as this one. Again, in the lead V1 to V6, there might be deep S waves. It is contrasting to the points that we discussed, and this is mostly a finding of type C RVH because of pulmonary diseases, and this could also be one of the finding in QRS. And S1, S2, S3 pattern, which we'll discuss in later, this is going to be seen mostly in adults. So your limb leads, which is S1, S2, and S3, will have deep S waves present in them, right? So they're going to have deep S waves. For example, this is lead 1. This is how it's going to look like. The S wave is going to be deep. So quickly revising what happens to the P wave and ST segment and T wave is P wave is going to have P pulmonal, which is nothing but your tall and peaked P wave in the mostly inferior leads. This is your P pulmonal. And what happens to ST segment and T wave? So ST segments are going to be depressed, and T wave inversions In the precordial leads, mostly the V1 and V2, which are looking at the heart. So it's same as LVH with strain pattern, but in most of the right-sided leads instead of the left-sided leads. So let's just again understand three types of RVH from ECG perspective and what are the changes that you want to see in these three types of RVH. So whatever changes we have mentioned, like tall R in V1, V2, or maybe V3, is going to be present in type A RVH, which is due to the pressure overload. There might be such monophasic R, which looks like this instead of the Q and R, S complexes, which can be present in lead V1, RS more than 1, as I discussed before. And this is the type of RVH where you're going to have the most axis deviation because there's a hypertrophy of the muscle, the thickness of the muscle. In the type B, which is volume overload, like your ASD, you're still going to have R more than S in lead V1. This is like a RVV pattern, maybe incomplete or complete, where you have just like M pattern in lead V1, and axis is still going to be 90 degrees, which is right axis deviation. Type C RVH, which can be due to pulmonary reasons, is still going to have axis of 90, but your S wave, this is the RVH, which is almost going to look like normal ECG because the S wave in R is going to be more bigger than the R. And as we mentioned, one of the criteria is deep S wave from V1 to V6 that is present in this type of RVH, which is type C. And just because there are deep S waves, you're going to see RS complexes from V1 to V6 leads. So this is how the changes in the ECG are going to be while dealing with the RVH. Quickly move on and to revise the causes of, not causes, how the ECG changes of acute PTE look like. So we know that sinus tachycardia and also the incomplete RBVB, which you can see in lead V1. These are the most common changes in PT. The incomplete RBVB just looks like you're gonna have small r, deep S. This is how it's gonna look like, and that is going to be less than 120. So that is called as incomplete RBVB. This is how the acute PT looks like. But there are a few other things which you need to look out for. Of course, acute PT is gonna have right axis deviation because it's some sort of type C RVH. So any of the RVH is going to have right axis deviation. S1, Q3, T3. This pattern is in lead 1. You're going to have deep S wave, and lead 3, you're going to have Q. So this is your deep Q wave, and this is inverted T wave. So this is what is called as S1 Q3 QT33 pattern, which is very among the specific ones for diagnosing PT. Like I said, RS R dash pattern, which is your RVV pattern, is gonna seen in V1. We were gonna have different sort of morphologies. There might be just QS, which will look like this. There might be QR, which will look like this, no S wave, or R, as we mentioned, R more than S, which is a type, which is a classic for type A and B RVH. So persistent S wave, like just like your type C RVH, because of cor pulmonale, there can be persistent S waves or small RS complexes from lead V1 to V6, and this persists in lead V6 even after resolution of PT. So these are some of the common basic changes that you might expect in the ECG. Most commonly we see this. We see sinus tachycardia, we see some RVV picture, and lead V1 for any types of morphology. And the way to diagnose PT is your echo, CT pulmonary angio, D dimer, and various clinical scores and the high level of suspicion. Acute PT is an emergency, should not be missed, and hopefully we get on to revise acute PT sometimes in the future as well.